Upon completion of this section, attendee will be able to verbalize common terms associated with ventilators. These cartoons portray the importance of our documentation. The cartoon on the left is saying, your insurance won't cover a ventilator any longer, so Bob here will be giving you mouth-to-mouth for the next several days. The cartoon on the right is saying, your insurance is refusing to cover our top-of-the-line machine, so we have to make a switch here. Both of these show that our documentation is important. Please remember to document what you are doing in the home and any changes that you have made and the response. These are some of the common ventilators that are in home care. The top three is primarily what we see. We see the Pulmonedic LTV 950, which is being phased out at this time. It is being replaced by the Pulmonedic LTV 1150. And we see the Respironics Trilogy 100. When we get a client that's on a ventilator, we want to know why. Why does my patient have this ventilator? Is it a neurological reason, a neuromuscular, pulmonary, premature, or cancer? Every one of these has a different outcome and has a different disease progression. By knowing a little bit about the disease progression, we can make very informed decisions to help our client out and be their advocate. Some goals in mechanical ventilation. Ultimately, we would love to see our clients weaned from their ventilators. Not realistic for a lot of the population that we see. If we cannot get them off of their ventilators, we want to make sure we adequately oxygenate and ventilate that patient. Oxygenation and ventilation are two very different processes. Oxygenation is the process of bringing O2 into the body. Ventilation is the process of getting rid of the CO2. Ventilation is slightly more important. If we cannot get rid of the CO2, we cannot take on the oxygen. We want to reduce the work of breathing. We want to assure that the patient and the ventilator are in sync with each other, and we want to avoid high peak pressures as much as possible. Here are some of the terms that are associated with ventilators. The first one is tidal volume. Tidal volume is the amount of air that passes in and out of the lungs in one breath. As our patients grow, or as their disease progression either gets better or even worse, we may need to adjust this number. Tidal volume exhaled. The amount of air that is exhaled. What goes in must come back out. It should be within 50 cc's on a closed system. A closed system is a trach with a cuff that is inflated. For example, if I had a patient that had 500 cc's of air going in, I would expect to have 450 or greater cc's of air coming back out. Minute ventilation, or minute volume, is the amount of air a person exhales in a minute. It is actually a flow. It's naturally lower with the rest, and as we do activity, it increases because of our demand for more oxygen and increased production of CO2. A person's minute ventilation will increase in times of stress, which is reflected in an increased respiratory rate. IE ratio, or inspiratory time. It's inspiratory time versus expiratory time. How long do we have to inhale versus how long do we have to exhale? Exhalation is typically twice as long as inhalation. This number can be adjusted so that the patient does not buck or fight with the ventilator. This can be done by contacting your DME company and telling the respiratory therapist what your concerns are. They will come and evaluate your patient and see if any adjustments need to be made. Oxygen and ventilators. Keep in mind that with oxygen that is bled through a ventilator, there are no alarms on home care ventilators if the O2 source is not working properly or it has become disconnected. Some of the newer ventilators may have an oxygen analyzer in place that it may alarm if the oxygen becomes disconnected. Just keep in mind that you need to be checking your oxygenation connections frequently. Sensitivity. When you hear the term sensitivity, it is the amount of negative pressure required to trigger the ventilator for a breath. How long do I want my patient to work in order to be able to get a breath? If we set this number high, it causes weak patients to be unable to trigger a breath at all. If we set it too low, it may lead to autocycling or overventilation. A typical setting is somewhere between 2 and 4. Autocycling is when the ventilator cycles faster than the set respiratory rate, usually due to a leak in the system or patient. In other words, the ventilator actually thinks the patient is attempting to draw a breath, but in fact it is detecting flow from a leak or movement. With autocycling, we need to find out what the source is. What is happening here is they are getting breath after breath after breath after breath and are unable to actually get a breath. They are getting puffs. We will have some autocycling that happens just by rearranging the patient, turning them over in bed. Maybe we are taking them for a ride in the vehicle. If it gets to be too much, if we have a range for a sensitivity from the physician orders, we can go ahead and adjust it so that the number is higher. Higher is harder, so it will be harder for the ventilator to sense this and harder for the patient to be able to take a breath. When we reach our destination, we can go ahead and turn it back to a normal range. Pressure support is used to decrease the patient's work of breathing on inspiration when breathing spontaneously. You will not have a pressure support setting if the patient cannot take breaths completely on their own, even if it's just a tiny breath every now and then. Pressure support eliminates the increased airway resistance that the trach creates, which makes it harder for the patient to take any spontaneous breaths. We are used to breathing through a tube which is a little bit less than an inch in diameter. Now we are expected to breathe through a tube about the size of your pinky finger. There is a lot of resistance with this, and it will make it hard for them to take any breaths. We want to encourage our clients to take breaths on their own to keep their muscles strengthened. This is a very helpful setting in weaning because it decreases the muscular work with breathing and helps with CO2 removal. PEEP, or positive end expiratory pressure, is the amount of pressure we leave in our lungs after exhalation to prevent expiratory alveolar collapse. It helps to maintain an open airway, and it helps improve oxygenation by keeping that airway open longer. We have a natural PEEP in us of 2 or 3 centimeters of water. Because of this, when we put someone on a ventilator with a trach, they lose that PEEP. So this is how we reinstate that in their system. Peak inspiratory pressure, or PIP, is the highest pressure reached during inspiration. This number can be the most important number on a ventilator, so you want to know your patient's normal. As compliance decreases, the pressures are going to increase. So for example, I had a patient that her normal peak inspiratory pressure was between 14 and 19. It will vary on each individual patient as their disease processes and lungs are all different. Because I knew her normal was between 14 and 19, I could tell if her lungs were being more non-compliant. For example, possibly watching her peak inspiratory pressure, I may see pressures down to 12, I may see pressures up to 22. Then I might see pressures going up to 24, 26, she may cough, and it comes back down to that 19, 18 range. Well, sputum was in the way, so therefore when she coughed, she moved that sputum out of the way. Then if I saw it raising over a whole full shift, or maybe I hadn't been there for the day before or a couple days, and I was looking over her numbers, I would see that her peak inspiratory pressure had been creeping up and staying up there. This was a signal for me with this particular patient that she was becoming ill, and I knew that we had to start her on an antibiotic before her sputum turned colors, before she started running a fever or had other symptoms. This is a way to be proactive with your patient and not having to be reactive. There is lots of reasons the pressures can be increased. Like I said, it is due to a compliance decreased because maybe they have increased mucus in their airways. They have a trach obstruction or occlusion, bronchospasm. They may cough, they may be laughing, straining, agitated. They may have some atelectasis or pneumonia starting, or quite possibly their disease could be progressing also.